Hi, my name is Amy McGuire, and I am the Director of Women's Services here at Wellington Regional Medical Center, and we would like to welcome you to our Facebook Live posting. Thank you so much for turning in today to take some time with us to learn about breast cancer in honor of Breast Cancer Awareness Month. With me today, I have Dr. Andrew Shapiro. Thank you so much and welcome.
Hi, Amy. Thank you. My name is Andrew Shapiro. I'm a breast and general surgeon. Been in practice in Palm Beach County since 2006. Prior to coming to Palm Beach County, I spent my youth in New York City. I grew up in New York City. Did my training in Ohio, both in Cleveland and Dayton. I did my surgical residency in the Army at Eisenhower Army Medical Center in Augusta, Georgia. And after my training, I was stationed at Fort Polk, Louisiana, a hospital called Bain Jones Army Medical Center, where I was the chief of surgery prior to relocating here in Florida in 2006. As I mentioned, I'm in private practice. I have an office here on Wellington's campus, and my practice covers not only breast, but the full scope of general surgery as well.
So let's start with the basics. What is breast cancer and how is it detected?
So breast cancer basically is just an abnormal cell. Breast cancer, breast tissue is normal cells, and when those cells go bad or they have mutations, they turn into breast cancer cells. And then when those cells grow, they can form a tumor or a breast cancer. The most common way that we identify breast cancer is with screening mammography or a mammogram. And when we're able to identify it with mammogram, it's usually at a very small early stage. Unfortunately, as those tumors grow, sometimes they can form masses or lumps, and unfortunately, oftentimes that's how a woman will detect that cancer as a palpable lump in her breast.
So how common is breast cancer?
Yeah, so unfortunately, breast cancer is very, very common. It actually will affect about 1 out of 8 women, or about 12% of the female population. So it's a very common cancer. It's actually the most common cancer to affect women in the United States.
Are there different types of breast cancer?
There are several different types of breast cancer, and they basically broken down on how or where the breast cancer has started from, what type of tissue. So there's 2 main types of tissue within the breast. There's ductal tissue and lobular tissue. The ductal tissue are the cells, the ductal cells are the cells that line the milk ducts or the tubes that carry the milk from the lobules, which is the other type of tissue in the breast, to the nipple. So you can have ductal cancer that arises in the ductal cells and lobular cancer that arises in the lobules or the milk-producing part of the breast. There's some other types of tissue, stromal tissue, lymphatics, blood vessels within the breast as well, and there are some other less common types of breast cancers that can form in those types of cells. The ductal tissue can form 2 types of cancer mainly. One is a ductal carcinoma in situ, which is a non-invasive type of cancer affecting those ductal cells, and the other is an invasive ductal carcinoma, which accounts for about 80% of all breast cancers. The lobular carcinoma, or invasive lobular carcinoma, accounts for about 10% of all breast cancers.
So what are the risk factors associated with breast cancer?
Yeah, so there's a whole host of things that we think contribute to a woman's risk of developing breast cancer. One of the biggest risks is a prior history of breast cancer. So if a woman's had breast cancer already, that certainly puts her at increased risk of developing a second breast cancer. If a woman has a family history, specifically a first-degree relative with breast cancer, that also is a risk factor, places her at a slightly higher risk of developing breast cancer. There are some other factors like gender, so being a woman is an increased risk. Age is an increased risk as we get older. Again, 1 out of 8 women, so the longer a woman lives, the more likely she is to be 1 out of those 8. There are other risk factors associated, obesity, alcohol consumption, smoking. Many of these are controllable and can be changed. Some of them, however, can't be changed.
So at what age should a woman consider getting her first mammogram?
So there's some disagreement in guidelines as far as when women should get their first mammogram. What I recommend is that a woman gets her first mammogram sometime between the age of 40 and 45. However, if she does have a first-degree relative with a history of breast cancer, we recommend that she get that first mammogram 10 years before the diagnosis of that first-degree relative. So for instance, if her mother was diagnosed with breast cancer at 45, we'd recommend that woman get her mammogram, her initial baseline mammogram at 35.
So is there a genetic connection with breast cancer?
Most breast cancers are spontaneous mutations or spontaneous change in the cell's DNA, but about 5 to 10% of breast cancers are inherited or have a genetic component. And that's where there's a genetic mutation within those cells, and that genetic mutation is passed on from one of your parents. So about 5 to 10% of breast cancers are genetic inherited breast cancers. The most common genes that you've heard of, I'm sure, are the BRCA1 and the BRCA2. There's probably about a dozen or so genes that have now been identified to be involved with breast cancer risk. Some of the other ones are the PALB2 and the CHEK2 mutations, which also have been identified to increase a woman's risk of breast cancer.
So what can a woman do to prevent breast cancer?
That's a great question, and something that everybody wants to know. How can I avoid this? Well, unfortunately, there's really no surefire way to avoid getting breast cancer. One of the things, or some of the things that you can do, are certainly modify those risks that can be controlled or changed. We always recommend maintaining a healthy body weight, not being obese or overweight. We recommend an active lifestyle. They say that you should participate in about 150 minutes of exercise a week. It doesn't have to be all at once. It doesn't have to be the same amount every day. But over the course of the week, you should engage in about 150 minutes of exercise. You should avoid tobacco. Smoking is definitely a risk with not only breast cancer, but other types of cancer as well. We recommend alcohol consumption in moderation. The recommendation is no more than 1 drink per day for women, 2 drinks per day for men. The last thing that we talk about trying to modify your risk is avoiding hormone replacement therapy. So as women are in menopause, lots of times we like to try to control those menopause symptoms with adding hormones or exogenous hormones. And adding hormone replacement therapy has also been associated with a risk of developing breast cancer.
So what are the treatment options for breast cancer?
So there's definitely options available to women who have been diagnosed with breast cancer. There's not one operation for everyone that has breast cancer. A woman does have options. And the 2 main options are breast conservation, or what we call a lumpectomy, or a mastectomy. With a lumpectomy, the operation involves removing the cancer and a rim of normal tissue surrounding the cancer, but leaving the rest of the breast alone, compared to a mastectomy where we remove the entire breast, all the breast tissue. Now, when a woman has a lumpectomy or saves her breast or has conservation, as we call it, most of the time that woman does require radiation to complete her treatment plan of the breast. Most of the time when a woman has a mastectomy, that radiation is not required. Some cases, a large tumor involving the chest wall or bulky or enlarged lymph nodes may require radiation with a mastectomy. But for the most part, small tumors with a mastectomy are not requiring radiation. Now, a woman who opts for a mastectomy has options as well. So some women who elect to remove their entire breast can have a plastic surgeon get involved and have reconstruction of that breast at the time of her breast removal as well.
So based on all those, how does a woman really decide what option is best for them?
That's something we deal with every day in the office and have heart-to-heart conversations. There's no wrong answer. It's really truly a personal decision. The right decision for patient A is certainly not necessarily the right decision for the next patient that walks in the office. So it's truly a personal choice. The thing to remember is that there's no survival benefit when we compare a mastectomy, a woman who loses her breast, compared to a woman who has breast conservation. As long as that woman who gets the lumpectomy also has the radiation, the survival is the same between the 2 groups. So a woman who opts to have her breasts removed does not live any longer, stage for stage, age matched, compared to a woman who opts for breast conservation. So it's really a personal choice, very personal decisions. It has to do with the perception of their breast as part of their self-identity, their femininity, their appearance. It's a decision that's made in conjunction with their family, their friends, and certainly their breast surgeon and the other members of their treatment team.
So going back to prevention, we talked about mammograms. Is there a time that you stop getting a mammogram?
So the guidelines differ and disagree with this as well. We typically recommend routine mammography until the age of 80. It really boils down to how healthy a woman is. So if a woman is not healthy and her long-term survival is not more than 10 years, we don't necessarily recommend continuing mammography. You have to remember the whole goal of mammography is early detection with the goal of preventing mortality or death from breast cancer within 5 to 10 years. If a woman's not expected to live more than 5 or 10 years, there's really no benefit in extending that mammogram. So it's definitely something that as a woman ages should be a conversation that's had with her primary care provider, her gynecologist, or breast surgeon, whoever's involved with her breast cancer screening.
So over the last 2 decades, breast cancer deaths have been declining and survival rates are quite high. What do you think has led to that?
So one of the things, again, as I mentioned, is screening and early detection. So we've got wonderful technology now with our mammograms, our digital mammograms, our 3D mammograms with tomosynthesis. All of these advances in radiology and in mammography have allowed us to identify cancers at earlier and smaller stages or smaller sizes. And by identifying them when they're earlier and smaller, it certainly has an impact on survival and decreasing that death rate and the mortality from breast cancer. The other thing that I think contributes largely to the decrease in the death rate and the improved survival is the fact that we've got excellent chemotherapeutic medications or cancer drugs, as well as anti-estrogen medications that we're using nowadays that are just wonderful at prolonging women's lives and treating these breast cancers.
So is breast cancer only a woman's disease?
Yeah, it's not. About 1% of breast cancer can affect men, and so it's very important that men are mindful of the fact that they can get breast cancer, that they don't blow off or minimize anything abnormal in their chest or their breast tissue. If they notice any lumps or bumps, they should bring that to the attention of a doctor. Certainly if they have a family history, that's something that they want to talk about with their doctor as well, and make sure that they're examining their own breast tissue and their chest as well, because it does not only affect women.
So I heard there's a new treatment called IORT, which can reduce your treatments down to just possibly one treatment. Can you tell me about that?
Right. So IORT stands for intraoperative radiation therapy. And as we mentioned earlier, when a woman saves her breast or has breast conservation, radiation is required to complete that treatment plan in most situations. Traditionally, radiation would be delivered from outside the breast, what we call whole breast therapy or whole breast radiation, typically delivered in multiple fractions or multiple treatments. There's a total dose that's given, and then each little treatment adds up to the total dose. And when it's delivered from outside the breast, it's typically administered over a period of 3 to 6 weeks. So once a day, 5 days a week for 3 to 6 weeks to get to that total cumulative dose. With IORT or intraoperative radiation, we're able to deliver that entire total dose at one setting, one dose, one time. And the way that's done is at the time of lumpectomy, so while a woman is under anesthesia and we've done the operation to remove the cancer and perform the lumpectomy, we bring the X-ray machine, the radiation machine, into the operating room. We place the insert into the breast cavity, into the lumpectomy cavity where the tumor was removed from, and then we deliver the radiation directly into that lumpectomy bed. And we're able to deliver that total dose one time while that patient is under anesthesia. And then at the end of the operation, her surgical and radiation have been completed. And then depending on whether or not she needs any additional treatment with medication or chemotherapy would be determined on the pathology. But we're able to deliver one dose, give the entire radiation while they're under anesthesia. And that's something that we do have available here at Wellington Regional Medical Center.
So is everybody a candidate for IORT?
Most people are candidates, certainly depending on the size of the tumor or the size of the breast. Some women may or may not be eligible for that. But if it's something that's something you're interested in, if you are facing breast cancer and a diagnosis of breast cancer, and you're interested in that, it's definitely something to speak with your breast surgeon about, and the radiation oncologist, who would also be a member of your breast care team, about to see exactly if you are a suitable candidate for that.
Wonderful. Well, thank you so much for talking with me today, and we appreciate all of our viewers.